Okay. So my name's Sarah. I'm a first-year resident, one of the first-year residents, and we're going to be talking about pain today. So the first thing I wanted to go through is just some of the classifications of pain that we use to assess our patients. So somatic pain is just a throbbing and localized pain. So if people have a knee ache or joint ache, that would fall into this category. Visceral is more referred pain, so like pain from organs. You can't really specify a certain area. And then neuropathic pain, I feel like, is hot. During the last few years, everyone has neuropathic pain. And this is usually from healing or any type of nerve damage that has occurred. Then there's also acute versus chronic. So obviously, acute pain can be helpful. It tells you that something's wrong with your body and it's not normal and you probably need to go check it out. So it can help us warn of any potential harm, and a lot of times this is like surgery or an acute injury, people coming into the ED, this is their acute pain. Where chronic pain is a lot more difficult. It's usually months to years, and treatment can be very difficult, not knowing the underlying cause, trying to figure it out. So acute's going to be obviously within a couple days, and chronic is months to years. So just the first question, so a patient's describing their pain as throbbing, sore pain coming directly from their knee. What classification would this fall under? Yes, asomatic. Perfect. So how do we assess pain throughout different areas of the hospital? Some of the techs I've worked with have asked this question to me, so I included this in here. So this is the Universal Pain Assessment Tool. I'm sure you've seen it in doctors' offices. They have the faces on there. Scale of 0 to 10, with 10 being the most severe pain you've ever had. And this is mostly for our patients who are able to communicate, because you have to tell them how bad your pain is. And then we also have what we call CPOT, so Critical Care Pain Observation Tool. This is for our patients who are in usually the ICU setting. They are intubated, have a lot of pain and sedation meds going on, and they're unable to communicate sometimes what their pain score is. So as you can see, we look at different facial expression. If they're very tense, a lot of times they'll have their eyebrows close together, a lot of tension in the head, in the forehead. So that's a sign. And then body movements, if they're very tense and rigid, that could be another sign that they're in pain without communicating. And then also if they're able to vocalize, if they're screaming out, obviously something is wrong. So anything with a 2, we need to treat. So this is something that we use. You might see it in Epic. You might see a CPOT score, so this is what the nurses are measuring. So question 2, the Universal Pain Assessment Tool can be used for intubated, non-interacting patients. Right, false. So now I'm just going to go into some just common medications that you guys see. A lot of questions I get from the techs working on the weekends, or how does this medication work? What's like the max dose of this one? So I just figured I'd go through a very brief overview for you guys on just very general on how these work and just some common things you might see in the pharmacy. So these COX-1 and COX-2 inflammatory markers, these are what we call like inflammation inducers in our body. And as you can see, when an injury or something happens abnormally in your body, these are going to release. And they increase inflammation, like prostaglandins are released, as well as any type of inflammation. And it also can regulate your body temperature. So for one of the medications that are really common, acetaminophen or Tylenol. So this actually works by inhibiting the prostaglandins in your central nervous system, which prevents inflammation and pain. And we also use it for fever. You know, sometimes you have a fever, you take Tylenol. So that can also help bring down your temperature, your body temperature. And we usually dose this 10 to 15 mg per kg per patient. A lot of the times you'll see like the 325 milligram tablets, and then we have the IV formulation, which we try to avoid because it's expensive. And so we also have suppositories for patients who can't take PO, which we try to use first if possible. Oh, sorry. MAO is mechanism of action. Mechanism of action. Yeah. Oh, yeah, that's a typo, sorry. Yeah, mechanism of action. So non-steroid anti-inflammatory drugs, or NSAIDs, this is another one that is used quite commonly. This blocks directly at the COX-1 and COX-2. So this inhibits both pathways. So it's a little bit different than Tylenol. So again, it prevents the temperature and the inflammation process that is released in your body. So ibuprofen is 10 milligrams per kg. That's something that we use a lot. I think we use a lot of the tablets. Then aspirin's another one. Usually we don't use that for pain unless it was used for pain a long, long time ago, but this is usually going to be for any cardiothoracic disease. Indomethacin, that one's used mostly outpatient. I don't think we dispense a lot of that here, but it's something you could see. Naproxen's another common one that's in the outpatient setting. And then ketorolac is another NSAID that's used quite frequently, more in the ICU setting, since it is IM or IV. This one is very potent and has a high risk of bleeding, so we limit that to 5 days of therapy. So that's something, as a tech, you can help us watch out for if you see a lot of it being dispensed for one patient. Just, doing a double check, like how many days do they have this? That's always something that we look out for, and that one should not be taken with any other NSAIDs or anticoagulation medications.
So where does it cause bleeding?
Mostly in the GI tract is where most of the bleeds occur, but that's not to say it can happen anywhere else. So sometimes if it's like severe, I don't think brain hemorrhages are really common, but it just increases your risk for bleeding overall. And all of these really can, but mostly GI bleeds are what we see with these medications with chronic use. So musculoskeletal, this is another pretty hard pain to treat. As you can see, this is a muscle fiber, so like your arm muscles. And then you have your ascending pathway, which goes into your central nervous system, and which triggers the response to tell your brain you're in pain. Then you have your descending pathways along this line to have that pain sensory out. So like you pinch yourself, it travels to your brain and tells you you're in pain, and you feel it. So these are some of the medications that are used for specific musculoskeletal pain. So baclofen and cyclobenzaprine, those are the ones used pretty commonly, I think. I don't know, have you guys seen that one a lot being dispensed? Yeah. So those two work by inhibiting the ascending pathway. So it blocks this area, so your brain doesn't sense the pain. And then tizanidine, which is my least favorite one, it works a little bit differently. There's an alpha-2 receptor in your central nervous system, in the dorsal horn, where this is showing right here. And it blocks it specifically in your CNS, which has a lot of other side effects. A lot of the main ones we see is hypotension. So a lot of patients will have a drop in blood pressure when taking this medication. So that's something as pharmacists we look out for. And there's a lot of drug interactions. It's contraindicated in Cipro, an antibiotic. And that one can cause severe hypotension where patients can actually pass out. So that's something we really watch with that medication, which is why I don't like it that much. So then our lidoderm patch, we dispense a lot of this. This one's a topical patch, 12 hours on, 12 hours off. And you can actually cut this patch. I know some you can't, so if you get that question, that would be useful. Does anyone know why we wouldn't apply heat to this patch? Okay, well, I'm going to tell you. So if you apply heat to the patch, it releases more lidocaine than what is actually slow release through the patch, so it can cause some systemic absorption and can lead to arrhythmias and death. So don't apply heat to these patches if that becomes a question.
Does like a patient with a high fever
that is not transmitting nerve signals.
Sorry, what?
The patient has a high fever, is it that sensitive, or is it like?
I think it would release maybe a little bit more, but it's mostly a localized intense heat, like a heating pad. Because most of the time people use it for like back pain or like a shoulder pain, and they'll want to apply heat onto it as well. So that's just like a counseling point, just to tell them not to do that. Because sometimes it's very dangerous. I'm about to show you this video right here.
What happens when the cell is stimulated? A stimulus changes the permeability of the cell membrane to sodium and potassium ions. This alters the distribution of charge in the cell body, and if the change is great enough, it triggers a signal, called an action potential, that moves down the axon. How does the action potential move along the axon? Voltage-gated channels in the membrane open and close depending on voltage changes across the membrane. When no nerve signals are being transmitted, these channels are closed. A stimulus causes voltage-gated sodium channels to open, and sodium ions rush into the cell. The cell becomes positive on the inside and negative on the outside.
So right there, that action, that's where lidocaine blocks it. So that sodium cannot go into the cell and trigger the action potential down the axon. So it inhibits your nerve stimulation pretty much. Does that make sense? You guys make? So again, other neuropathy meds, gabapentin. I think everyone has gabapentin. This one is dispensed a lot. And mostly they're in the capsule form. This one is technically, we're not really sure how it works, but we think it's similar to pregabalin, which I'll show you how that works in a minute. But basically, at the end of the neuron, there is a calcium influx to release more neurotransmitters, and it blocks that calcium channel to prevent further stimulation of the nerve. It's just at a different part in the nerve, which I'll show you here. So this is the end of the nerve, end of the axon, where it goes into the synapse.
An action potential arrives at the presynaptic terminal, causing voltage-gated calcium ion channels to open, increasing the calcium ion permeability of the presynaptic terminal cell membrane. Calcium ions enter the presynaptic terminal and cause vesicles to release their neurotransmitter acetylcholine from the synaptic vesicles.
So that calcium influx, that is where the pregabalin and gabapentin work to prevent further excitatory neurons from being released from the neuron. Yeah, so that's how we believe GABA works, similar to pregabalin. And then carbamazepine is one that's further down the line that we used. This one also limits the influx of sodium, similar to fentanyl. But that one is also used for anti-epileptic. It's just something that can be used down the line, but it's not very common for pain.
So gabapentin and Lyrica, they have the same mechanism of action?
They're very similar. It's like kind of unknown with gabapentin, but we think it works similar to pregabalin. Yes. There's some drugs we don't know exactly how they work, which is kind of scary. So now opioid pain management. This is pretty common. So again, you have your neurons here, and the opioids inhibit the mu receptor to prevent the reuptake of the pain medication, so you have more of the transmitters that make you feel good and that you don't have any pain. Is basically how this works.
Can you say that once more?
Yeah. So your opioid receptor right here, it's going to block the mu opioid receptor, and then so it'll increase a bunch of these neurotransmitters that make you feel good, pretty much. So like serotonin, norepi, it works on that as well.
Okay.
Yeah. And then oxycodone we dispense a lot of as well. These usually come in the 5 milligrams tablets. And the hydromorphone is another one. And this one can also come in an infusion, an injection as well. So you might see some of that for more of the ICU patients who need IV medications who aren't able to take PO. Fentanyl's kind of interesting. It actually increases the pain threshold. And so that means for me, I'm a big baby with pain. So if I put it on, it might help me. If I use fentanyl, it might increase that threshold as well as helping with your pain. And these are usually patches, but they also come in syringes, IV, and most of the time we use this in the ICU for our sedation patients with a CAD pump. It can be used as well. So this is just a conversion chart. I just copied the one on the back of our badges here. This is another question I get from some of the techs. how do I know how much morphine equals like IV hydromorphone? What's the potency of each medication? So I included this just for you guys to reference. And I put in a math equation if you guys would like to do it. If not, we can walk through it together. So if a patient takes oxycodone 10 milligrams every 6 hours, how many milligrams of PO morphine is this equivalent to? So if you look here, so 10 milligrams of PO oxy equals 15 milligrams of morphine. So if you have every 6 hours in 24 hours, that means you're taking 4 tablets a day. So then 4 tablets times the 10 milligram tablets equals 40 milligrams. And then you just do the cross multiply conversion. So 10 milligrams of PO oxy equals 15 milligrams of PO morphine, and he's taking 40. So you calculate that, you cross multiply, and you get 60 milligrams of PO morphine. Patient-controlled analgesia, so this is PCA pumps. A lot of them are usually IV. That's the most common form we have for patients. And then epidural is probably our second most common, mostly for delivery and labor. Sub-Q can be used, but we don't really use it that much. I've never seen it used here yet. And these are usually through the Alaris pumps. So you can have continuous, you can have patient boluses, or a mixture of both. So I included just an example. So fentanyl 50 mics per hour, continuous with 25 mics every 15 minutes with patient lockout.
What is the meaning of patient lockout?
Yes, so in this picture, so you see the PCA syringes, we put that in the Alaris pump and we program in that order. So every time the patient pushes a button, it'll deliver the medication and then lock them out for that 15 minutes. And if they keep pushing the button, it won't give them any more medication. So that's sometimes you'll hear like, oh, they have a 15-minute lockout period. So that's what that is meaning. So yeah, that's just a picture to show you. So they push the button and it gives the medication. Again, the patients have to be awake and oriented enough to do this. So sometimes that can be challenging for some of your intensive care patients, which is why you can do it continuous as well. So just another example math question. So if you get a PCA order that reads 75 mics per hour of fentanyl with a 25 mic push with a 10-minute lockout, how much fentanyl can they get in an hour? And sometimes, as pharmacists, we'll calculate this when an order comes through to make sure it's appropriate. So they have 6 intervals per hour, so times 25 mics, that's 150. And then 150 plus the 75 they're getting per hour, that's 225 mics of fentanyl. So you can compare that to what they have been getting, how much total fentanyl they're getting, how much times they're pushing it, and seeing if that's appropriate. So overall pain management, what we do every day, or what we should be doing every day, it's always good to get a patient history and their baseline pain score. And we continually assess this either multiple times a day and at least daily, especially in some of our ICU setting. We probably reassess this multiple times throughout the day. Something that UVA does here is you can only have one medication for each pain severity. So we have mild, moderate, and severe. So that's something we look for as well to make sure that they're not doubling up on moderate. And it helps with the nurses so that they aren't, so basically they're not diagnosing someone's pain severity. So that's already established, and the patient can tell them what score they want, and the nurse gives the appropriate medication.
I have a stupid question.
There are no stupid questions.
Why any used? Is that something intentional?
For
The previous slide, overall pain.
yeah, in the beginning it was like a movie joke, like major pain. It's just like supposed to be funny and like keep you interested throughout. Yes, I know I spelled that wrong for a reason. Yeah. Thank you though. So the CDC recently published some new opioid management guidelines. So this is targeted for adult patients with chronic pain. So opioids are a high risk for all patients, no matter their age and previous opioid history. They really are emphasizing non-pharmacological therapies first. So cognitive therapy, a lot of times there's an underlying like mental or psychological issue that's really important that needs to be addressed. So they need to talk to a professional about that. Exercise and stretching has shown to help a lot, and massage and physical therapy have been shown to help. And obviously emphasizing non-opioids first, so like our Tylenol, ibuprofen for more acute pain. And then if you must use opioids, starting low and increasing very slowly. And again, reassessing at every visit and close follow-up is very important. So just a question. A patient is describing a new acute onset of pain in their upper shoulders and neck. They describe the pain as coming from their muscles. Based on the new guidelines, what appropriate prescription would you prescribe for this patient? Yes. So it's not really a prescription, but trying something else first. So I hope this answered some of your pain questions that I've gotten just working with techs. I figured it would be a little helpful for you guys. Do you guys have any questions for me?